Welcome, my name is Andy Crossman. I'm a board-certified behavior analyst and the executive director at Journeys. And today we're going to be talking about ethics. Now initially when I received ethics training, I thought, this isn't for me. At our agency, we don't have ethical dilemmas. We always do the right thing and we encourage everybody to do the right thing. I don't have anything to learn here. Boy, was I wrong. Let me tell you, the world is not clear-cut, binary, cut and dry, black and white, right or wrong. The ethical code we're going to be talking about today has so much more to do with right and wrong, but it's about how we make the best choices, how we best serve our clients, how we get the best outcomes for them based on our behavior. As we do so, we're going to be looking at what are the industry best practices. We're going to look at Idaho IDAPA code to see what are our regulations and obligations to them. And we're going to be using the Behavior Analyst Certification Board's ethical code as our framework for doing so. The ethical code is divided into 10 separate sections. This first video will cover sections 1 and 2. The second video we're going to have will cover sections 3 through 10. And then the third video we're going to talk about implications and applications of these ethical guidelines that we've received. So hang on, I'm sure you're going to learn something as we do so. Section 1 of the BACB Ethical Code is responsible conduct. Point 1.01 says we rely on professionally derived knowledge based on science and behavior analysis. The very first ethical guideline we have is we are science. We're using proven methodologies. We are using empirical, peer-reviewed, proven methods. I think a lot of times we take for granted that, I'm good with kids. Fantastic that you're good with kids. So is the science of ABA. Rely on that science. Use what is proven to work. 1.02 talks about our boundaries of competence. It states that as we're working with these individuals, that we stay in our lane, commensurate to our training, to our experience, to the level of disability, skills, and other aspects of intervention that we're comfortable with. We should never place you with a child that you don't feel comfortable working with. We should never have you teaching a skill that you don't feel like you have the skills to teach. We should never put you in situations or environments where you're not comfortable being the interventionist. As we look at our bounds of competence, we also make sure that we're sticking tightly to those IDAPA regulations in what is acceptable to bill for children's intervention services. Is this something that we should be doing as a developmental disability agency? Is this a skill that should rather be referred to an occupational therapist, to a counselor, to a speech therapist? Most of the clients that we serve have the opportunities to visit those specialists as they see. We need to make sure that we're remaining in those bounds of our training, of our competence as we're writing these plans and working with these individuals. Now, don't lose hope if you don't have all the skills you think are necessary. We're here to train you, we're here to support you, to get you the resources to be there. But we also recognize that many of the behaviors that our clients are struggling with, especially those that go to or come from emotional disturbances, from other coexisting psychological conditions, or perhaps gross or fine motor skills, are beyond what we do. 1.03 talks about professional development, that we have an ethical commitment that we're going to continue growing the longer we stay in this field. In order to become a behavior interventionist, you went through 40 hours of registered behavior technician training. That should not be the end of your training. You should be getting at least 6 hours annually of behavioral training, plus at least 6 other hours of training based on industry practices, policies and procedures, and other expectations that we have for you. Let me encourage you to take your training far beyond that. There are so many fantastic books out there, wonderful trainings available, and other resources that you can have to grow as an interventionist. Grow with us, develop with us, help us in being more effective in helping these kiddos change their lives. 1.04 in the BACB Ethical Code talks about integrity. We're absolutely going to cover this, but we're going to dedicate a whole chunk of our third video towards what it means to have integrity in this field. So we'll come back to that. 1.05 talks about professional relationships. When we look at our professional relationships, we need to make sure that we are the professionals. We need to make sure that we're speaking in understandable language, that we are using those principles of science that we talked about in the first principle here, and that we're keeping our personal lives, our personal issues, our personal holdbacks out of our intervention. As we do so, we're going to make sure that we show up ready to work every day. In doing so, let me remind you that when we go into a child's home, we're not the expert on that child, the parent is. If you're doing interdisciplinary training with another professional, we're there as their guest. Part of our professional relationships is recognizing who's the expert in the room. Sometimes that is us, but so often it's going to be the other individuals that we're there helping consult, offering our help and support to. 1.06 talks about multiple relationships. And as we look at behavior intervention, this is one that's very specific in our field and detailed in what those guidelines are. Multiple relationships refer to your relationship with a child or client and their family, and that if you have a relationship with them outside of that as their interventionist. You may be their neighbor. You may go to the same church congregation. You may know them from another part of your life. We're going to do our best to make sure that you're working with individuals that you're comfortable with, that they're comfortable with you, but that we're not struggling with these multiple relationships. As you can imagine, working with family members changes the dynamic of that relationship and that intervention. It's more familiar than it is professional, and it's important that we keep those professional boundaries. Another thing we always want to make sure happens is that when we show up to do intervention, that nothing else is owed to us or is owed to the family. One of the ethical guidelines that we receive from Medicaid is that they are the payer of last resort and that nothing is owed on top of their payment. If there's another relationship with you and that family where they feel like they owe you something else or they're giving you gifts, we're violating that ethical guideline that we've been given. We also want you to be able to impartially be able to switch clients, be able to offer recommendations, be able to do things without that being interfered by them giving you a gift, them owing you something, then some other relationship happening. So it's critical that we're avoiding and being mindful of any multiple relationships that may be happening with you and your clients. As we talk about Section 2 is our responsibility to those clients. One of the things that's unique about the Behavior Analyst Certification Board is they list 4 types of clients that we're serving. It goes far beyond just the individual that's receiving the intervention. They say the first client that we have is that child or that person receiving the intervention. Absolutely, they're a client. But we also have other ethical imperatives and directives to the parent, relative, or guardian, to an employer or agency representative. For instance, those of you that are working inside of a school, under a school contract, that school is also a client of ours, as is the teacher, the principal, and the other people in that school that oversee that contract. And then finally, any other individual that is a known beneficiary. We do intervention maybe on a soccer team or a ballet group, as part of a scout troop or a 4-H club. Those other members of that 4-H club or that team are going to be beneficiaries of a behavior change in that client. We have an ethical obligation that the behavior intervention that we're doing appropriately affects those people, that is not interfering in those people's lives, and that we are mindful of those individuals. As we mentioned, Section 2 in that ethical code talks about clients. 2.01 talks about accepting clients. As we're looking at the clients that we serve, we don't have a prioritized list of clients, and neither should you. We absolutely want you to be able to work with clients that are in your wheelhouse, working with ages, disabilities, genders, specific behaviors and environments that you're most comfortable with. But we also encourage you to accept any client that we have for you, as long as you feel it's within your bounds of competence. We don't want to pick favorites, but be able to offer our services to all of those who are able to receive it. 2.02 talks about our responsibility to all of those clients that we listed before. It's important to recognize that there's a hierarchy of attention and resources that we'd give each of those clients. I'm obviously not going to give the soccer coach as much attention as I am the client that I'm working with, but we do need to recognize his presence and him as a beneficiary and a client of my services. I encourage you at the outset of your services to be able to clearly delineate who is your client, what is your responsibility to that person, and where does that resource allocation and priority lie with each of those people. Your focus should absolutely be with the child that you're serving, but how are you going to meet your ethical obligations to each of those other clients? 2.05 talks about participant rights. Attached with this video is a list of our participant rights as found in IDAPA code. But today, as part of our ethics training, I want to talk about 3 specific rights that our clients have. The first one is the right of refusal. Any of you that are married or have kids know you can't force anybody to do something they don't want to do. So let's not pretend like as interventionists we're going to force our clients to do anything. Nothing about this field is about compelling or forcing a behavior. Our job is to teach, practice, evoke, and reinforce the right behavior. There are times when clients will refuse, and that's okay. That's their right, and that's something that we must honor. It's important that we remember also that a client doesn't have to be aggressive or violent for us to honor their refusal. We need to recognize that if a client doesn't want to participate in something, we honor that. If you're seeing too many of these refusals or are concerned about them, we advise you to go talk to your clinical supervisor, and they may have some ideas with you. We may have to have a meeting with the client and their family to talk about how we can better serve that individual, or maybe take a step back in that behavior plan. The second part of participant rights I want to talk about is that it states that the client has a right to courteous treatment. That's courteous treatment all the time. We demonstrate courteous treatment with the words that we choose, with the tone that we use, with the volume that we use. We demonstrate courteous treatment in every aspect of our behavior. Everything we do as an interventionist needs to be treating a client with dignity and respect and treating them as in a courteous manner. That is their right. The third participant right I want to discuss is their right to receive services that enhance the participant's social image, personal competencies, and whenever possible, inclusion in the community. It is their right that their services are age appropriate, that they are more independent because of the skills that we're teaching them, and that they are included in the community in what we do. That's why the majority of our services are happening in the home and in the community with their peers. The first question we should be asking about environment is, where would the client be if they weren't receiving services from us? That's where we need to be. There are times when we need to teach in a discrete, contrived setting to be able to go then take that skill and practice it out in that natural environment. But the goal in every intervention is to help our client be more independent, get to that natural environment, and help them to fit in and be a typical kid. Isn't that what we hope with all of these goals and for all of our clients? 2.06 in the Ethical Code talks about confidentiality. We've attached below a copy of our HIPAA policy from our Policy and Procedure Manual. It's important to remember that as a Medicaid medical service, we're under the same HIPAA regulations to protect our clients' privacy and confidentiality as any other medical office or medical service. This means we can't disclose any personally identifiable information about our clients. We need to protect that confidentiality, even the confidentiality that they're attending services with us. It's one of the reasons we don't carry big lanyards on us that say where we're from as we're providing services. Our job is to be camouflage as we're out in the community. That's how we're promoting their inclusion. 2.09 talks about treatment efficacy. It's important that intervention for our clients is working. We've all seen that our clients go through phases. We initially may see a honeymoon phase or a refusal phase, and then we're able to see progress trend from there. But we need to be looking at our data. We need to look at the results. We need to follow the trends, and we have an obligation to make sure the intervention is working. If it's not working, we need to take appropriate steps to change it. Part of our status review process is that we're resubmitting to the state the results of our intervention, and that should always show that we are making progress and making those appropriate fine-tuned changes as needed. 2.11 talks about records and data. We must be engaged in active treatment and always collecting data on the intervention we're providing. Please know that that intervention is not wasted space. That is not filler. We use that data, and it's critical that that data is accurate. In order for the data to be accurate, it needs to be taken in real time, during every session. It needs to be taken accurately, as prescribed in the program implementation plans. You should know what the behavior is that you're tracking, what indicates a correct behavior or not, and frequently we'll also have you delineate what was the prompt level used or what was the client's response to that service. As you're collecting data, even your own time, we need to make sure we're also following Medicaid guidelines as far as what is a billable unit. We track our time in 15-minute increments. In doing so, we stick to what we call the 8-minute rule. If you are more than 8 minutes past, we go to the next billable unit. So for an example, if you're scheduled with the client to begin your session at 3 o'clock, but you don't pick up that client until 3:08, we wouldn't record that session as starting until 3:15. The other side of that would be is if you're scheduled to start at 3 and you pick them up at 3:03, at that point, it's not yet to that half point, to that 8-minute mark. We can go ahead and record that data starting at 3 o'clock. We also need to be aware that many of the goals that we're working on won't take a full 15 minutes. Oh my gosh, can you imagine having to work on toothbrushing or flossing your teeth for a full 15 minutes? So we need to make sure we're recording that data accurately and that those program implementation plans is meeting guidelines for accurate record keeping and appropriate billable units. The last one we're going to talk about from Section 2 is interrupting or discontinuing services. We have an ethical guideline that we are providing services that we've agreed to provide. Part of that responsibility lies with you as an interventionist, that you are showing up to the sessions that you're scheduled for. These clients and their families are counting on this service. It's been found medically necessary. Proper assessment's been done to get the right goals at the right time in the right amounts. If you're not showing up for services, if they're seeing long interruptions or gaps in services, that interferes with the efficacy of treatment. We have an ethical obligation to be at those sessions that we've committed to. We also have a commitment that we don't just drop clients or discontinue services unnecessarily. As an agency, we go to lengths to make sure that that family is able to continue services in whatever ways possible if we're no longer able to serve them. That would be a referral to another agency, a referral back to Medicaid or health and welfare, but to make sure that we are not causing any unnecessary gaps in services. In summary, we want to make sure that we remain vigilant in our ethical obligations with our conduct and the way that we're working with our clients, in honoring their rights, in providing the right service at the right time, and in billing in the correct way. Stay tuned in the next videos to learn about other obligations we have as we're providing that service and how we get in and use these every single day.